Hi, I'm Dr. John Valdrighi, a board-certified anesthesiologist with over 20 years of private practice clinical experience. I'd like to share my experience with emergency manuals. The intended audience for this talk are healthcare professionals who work in a critical care environment such as the operating room, intensive care unit, emergency room, or recovery room. I have no financial disclosures. My interest in emergency manuals probably dates back to my undergraduate degree in mathematics. I've always been fascinated with protocol optimization and algorithms. And if you think about it, the emergency manual really is just a flow diagram you work your way through to get yourself out of trouble. Since my first smartphone, I've always found a way to put my notes on my smartphone, so I have them available in case of emergencies. I've even done some work to try to write apps so I could share these notes with other anesthesiologists. In the fall of 2015, the Anesthesia Patient Safety Foundation had a national symposium on emergency medicine manuals. I knew I had to attend. With a bit of persistent persuasion, I was able to get an invite from Dr. Stolting, president of APSF. Thank you, Dr. Stolting. I was one of the few private practice anesthesiologists at this meeting. This was mostly department chairs and program directors. When I returned from the meeting, I heard a distressing story from one of my distraught younger colleagues, a recent graduate from the Stanford anesthesia residency. He had gone to assist with a crisis that was occurring in our recovery. Here's how he tells the story. They weren't doing anything. They were totally disorganized. Where was the emergency manual? Now, when I was at the APSF meeting, I realized I'd never be able to get these manuals in our operating room. Why? Culture. We're a tertiary center with expert anesthesiologists, but we're a bit old school. A good anesthesiologist knows what to do and he just does it. Well, I'm going to try to demystify this myth a bit. But let me get back to my colleague, Dr. M's story. Now, I mentioned he was a Stanford graduate, not to name drop Stanford, even though they're an excellent institution, but because, as you'll soon learn, Stanford is a leader in emergency manuals. I now knew I had the ally I needed to get this accomplished. With my gray hair, I could be the bridge between our younger partners with no gray hair and our older partners who have no hair. At the next anesthesia education meeting, we presented emergency manuals. It was overwhelmingly positively received. We had the buy-in we needed from the anesthesiologist. But this was not enough. We still needed a committee approval in order to get these manuals installed in the operating room. Dr. M was a bit frustrated. Why do I need a non-anesthesiologist approval to put a book on my anesthesia cart? However, we soon learned that these committee meetings were a wonderful opportunity to educate our colleagues and build a culture of safety. My talk today is based upon that talk I gave a year ago to our anesthesia education meeting. There's still so much that can be done to build this culture of safety. Please send me your thoughts and ideas to john@safeforanesthesia.com. So let's start with a call for action. Like most doctors, I've got a stack of articles I've been meaning to try to find time to read. I see an interesting article in a journal, I rip it out and it sits in a pile. Recently I was going through my pile and I came across this editorial from Anesthesia and Analgesia. It was written by a surgeon who was very upset about the treatment his patient received during an intraoperative cardiac arrest. Here's what he wrote. Do you ever hold emergency drills in your operating room? Have you a plan of action so developed that the right thing is always done in the emergency and time is not frittered away with useless or non-essential details? A fixed emergency routine posted on the walls of every operating room. Okay, so I've taken a little liberty with this story. This was actually written by Dr. Babcock in 1924. I found this on emergencymanuals.org, which is a great website if you're interested in installing emergency manuals in your operating room. And of course, I hope everybody will be interested in doing this after this talk. This website has links to emergency manuals you can download for free, articles like this, and ideas on how to implement or make this process work. So why are we still talking about emergency manuals almost 100 years after Dr. Babcock brought this up? I'd like to go through some of the science behind emergency manuals. So why do you need an emergency manual? Dr. Goldenhaber-Fiebert and Dr. Howard in 2013 wrote a great nuts and bolts article in Anesthesia and Analgesia. And basically, under times of stress and time constraints, our executive function diminishes. And they give a few examples in their article. One example is the retrieval of inert knowledge. When you're under stress, it's hard to recall what we know. One example of this would be the 5 H's and 5 T's in advanced cardiac life support, possible reversible causes for cardiac arrest. Now, when I gave this lecture to my group a year ago, there was an instructor in the audience who had taught ACLS for 25 years. And he confidently volunteered to quickly rattle off the 5 H's and T's under the stress of being in front of his peers. And much to my surprise, he was able to mention 8 out of 10 of them. However, much to his surprise, he could only find 8 out of 10. So for those who are curious of what the 5 H&Ts are, here they are listed. A second area of executive function that diminishes under times of stress and time constraint is prospective memory for future tasks. That's forgetting to do something you intend to do. An example would be a hypotensive event in the operating room. You want to turn down the anesthetic agents. You want to give a pressor. You might start a vasoactive drip. So you push your pressor, you're calculating the dose for the vasoactive drip, and you noticed that you hadn't turned down the agent. Now perhaps if there was a list, or maybe even a reader with the list helping remind you, this would have been done sooner and you could have avoided some of the complications of the hypotension. A third way that executive function is impaired is working memory for calculations. I think we've all experienced difficulty calculating a dose when we're under time constraints of emergency. A great example of this would be intralipid dosing in local anesthetic systemic toxicity. Now it's estimated the average anesthesiologist will never see a local anesthetic systemic toxicity case in their career. And the protocol for dosing is pretty complex. So I ask you, what are the odds that you'll get this right if you're relying on memory while your patient's under a cardiac arrest? So here's from the ASRO website, American Society of Regional Anesthesiologists. And this is the lipid dosing. Use 20% intralipid. You bolus 1.5 milligrams per kilogram based on lean body mass over a minute. Continuous infusion after that. You may repeat the dose if there's cardiovascular collapse. You may have to double the infusion. Continue the infusion for at least 10 minutes, but the recommended upper limit is 10 mils per kilogram. Good luck remembering this as you initiate CPR on your patient you just gave an overdose of local anesthetic. So when we manage our cases, we draw from complex, evolving data to guide decision-making process. But emergency is not the time to look up the dose of intralipid. It's the time to act. Don't think, act. Actually, I would say with emergency handle, it's more act and think clearer. You've got the cognitive unloading by having this information in front of you, and you're more able to think about what you should do and what the next step is. So now I want to talk a little bit about the difference between checklists and emergency manuals. Clay Williams, in an editorial in 2015, was calling for applying aviation safety standards to healthcare. And he makes note that there are 2 categories of checklists used in the cockpit, normal and non-normal, or emergency procedures. Now, I think we're all pretty familiar with normal checklists, and this, in the business world, is called a standard operating procedure. This is how, no matter where in the world you are, you get the same high-quality McDonald's French fries. There's a cookbook. They follow the list, right oil, right temperature, right cut fry, right amount of salt, right amount of time. You follow the list, you're going to get high-quality, reproducible results. And when this is applied to healthcare, we've had phenomenal results. For instance, the incidence of central line infections, if you follow checklists, have greatly improved. And so this is the book Atul Gawande put out in 2010 that talks about checklists. And it's a bit confusing because Atul Gawande is also involved with Aaron Labs, the Harvard lab that puts out emergency manuals. So let me put in a quick plug for Dr. Gawande. This year, October 2017, he's the keynote speaker at the annual ASA meeting. I highly suggest you attend this lecture. So how is the emergency manual different? This is uncommon or rare events. This is not your standard operating procedures. Arriaga in 2013 estimated about 145 incidences in 10,000 operations, or about a 1 or 2% risk. So you don't need to use the emergency manual in every case. Or I would suggest if you are using the emergency manual in every case, you may need some career counseling. So here's how I look at the difference. A checklist is linear. You work your way down the list. This isn't typically for surprises. Where emergencies are not linear, they're evolving, you make an intervention, you reevaluate. So it's more requires clinical judgment, and it's not cookbook medicine. The emergency manual is just there to give you ideas and guide you as you work through the thought process. Let's talk a little bit about the nomenclature of emergency medicine. These are all things that refer to the same thing. Crisis checklist, crib sheet, cheat sheet, cognitive aid, reference card, handbook. Now, I've got a little bit of a bias against the term cognitive aid, even though it's widely used and accepted. I don't care which terms you do use. So we talked about the culture before. A strong doctor does not need to aid his cognition. So I think it's hard to call it a cognitive aid and have people willing to call for it in the time of emergency. But use whatever name you want to call it. Here's some examples of anesthesia emergency manuals that you're already very familiar with. Malignant Hyperthermia Association of the United States that has an MH protocol they put out. ASRA's got their local anesthetic systemic toxicity, which you've briefly already seen. And of course, there's the ASA difficult airway algorithm. Here's a copy of the malignant hyperthermia protocol, which you can download at mhouse.org. Now, it's kind of a blurry copy, which is probably appropriate because this is copyright protected. You've got to buy this copy from the website. Now, they are a nonprofit organization, and these funds go to supporting research in their hotline, so it's a very good cause. Here's the ASRA Local Anesthetic Systemic Toxicity Protocol, which you can download online from ASRA. And here's the ASA Difficult Airway Algorithm, which you can also download from the ASA website. So this is the same website I gave before, the 1924 Dr. Babcock article. And they have several downloads of emergency manuals you can do there. I want to talk about some of these. This is the Harvard Brigham Women's Consortium. The Ariane Labs, Dr. Gawande was instrumental in this in 2013. Their latest version of emergency manual is April 2017, and you can download this at www.projectcheck.org. Here's the Stanford Anesthesia Cognitive Aid Group. Their most recent manual was put out February 2016. They're on version 3.1, and you can download this at emergencymanual.stanford.edu. There's even an app you can download for pediatric emergencies. If you go in the App Store and you search PD Crisis, you'll come up with this application put out by CHOP, Children's Hospital of Philadelphia. And actually, there are some difficulties in maintaining apps. So if you want the most current data in a PDF form, I'd recommend going to www.pedsanesthesia.org and downloading that emergency manual. It's the same one as the app, but it's more up to date. There's even published manuals. This is the Stanford manual. First version came out in 1994. This is the most recent one in 2015. This is more of a textbook. It's got more in it, but it's more details to go through in time of emergency. Highly recommend this as a reference. There's even a manual put out by Lexicomp for dentistry. This is their fifth version, so they've been at this for a while. And this is the ACLS handbook I think we're all familiar with. The most recent version is 2015. Now, this also brings up a very good point. These emergency manuals, to be useful in a case of emergency, the format is very important. They have to be user-friendly. So Dr. Gaba, in an editorial in 2013, notes, the ACLS booklet summarizes literature and recommendations thoroughly, but experience shows that even its graphical flowcharts are very hard to read and to use. So what is the evidence supporting emergency manuals? Well, it's actually very difficult to prove that these are efficacious, and that's because emergencies are rare. So this is Arriaga in his study. He notes that owing to the relative infrequency of these events, a live clinical trial was not feasible. We used high-fidelity medical simulation. So Dr. Gaba in his editorial notes, we may never be able to prove with level 1A evidence, multiple well-controlled randomized trials, that using cognitive aids in managing critical events improves the patient outcome. The studies might need to last a decade, involve hundreds of thousands of institutions and tens of thousands of clinicians. So why even bother? We can't prove that this is effective. Well, I'd like to draw the analogy to pulse oximetry and look at the evidence behind that. And this is now an ASA standard for basic monitoring. So Barish in his 6th edition, 2009, notes, there are no definitive data demonstrating a reduction in morbidity or mortality associated with the advent of pulse oximetry. There was even a study done in Denmark in 1993 of over 20,000 patients. And with pulse oximetry, they found no significant difference in cardiovascular, respiratory, neurologic, or infectious complications, and an equal number of in-hospital deaths. However, they also noted that 18% of the anesthesiologists had experienced a situation in which the pulse oximetry had helped, and 80% felt that more secure when they used the pulse oximetry. So think about the emergency manual kind of like the pulse oximetry, and are you comfortable practicing without it? So hopefully now I've lowered the bar a little bit on what evidence we need to make the emergency manual scientifically acceptable. And as Dr. Gaba noted, absence of evidence is not evidence of absence. So what does the data show? In 2013, Marshall did a literature search. He found 23 scientific papers that used 22 different cognitive aids. And he concluded, current evidence for the efficacy of cognitive aids in emergencies is inconclusive. There's some 3 studies I specifically would like to look at: Arriaga, Neal, and Harrison. So Arriaga in 2013 looked at 17 teams in private and academic practice. This was done in Boston, 2 community hospitals, Harvard and Brigham Women's. They had 106 simulated cases, half with checklists, half without. And they had a checklist based upon best practices. And if you follow the literature, this checklist eventually became the Ariane Labs emergency manual. So this is the Harvard data. Here's the events they looked at. And here's what they found. If they used the checklist, 6% of steps were missed. If they did not have a checklist available, 23% of the steps were missed. And this was a statistically significant difference. And they found that, so they found a 75% reduction in failure to adhere to critical steps in management. Even more impressively, every team had a lower failure rate for adherence when the crisis checklists were available. So this helped everybody. And then they surveyed the participants, and 97% of participants wanted checklists available if they're having surgery. Compare this to the 80% figure we had with the pulse oximetry. Neal in 2012 looked at 25 trainees, 12 with a checklist, 13 with no checklist. And this was a local anesthetic systemic toxicity case based on the ASRA guidelines. He gave the guidelines out a month before the study without fanfare. He didn't say you're going to be tested on this in a month. And they're also available in their emergency binder, which was at every anesthesia workstation. They did this in a simulation lab, femoral block, spinal block for a total hip arthroplasty. And there was 28 items they scored on the checklist. The group that used the checklist performed significantly better than the group that did not. They got 16 out of 28 versus just under 9 out of 28. And then the group that used the checklist, some didn't use it fully, they just kind of looked at it, but the ones that used it fully, they did better than the ones that just partially used the checklist. So Harrison in 2006 did a malignant hyperthermia simulation, 24 first-year residents, 23 second-year residents, and they had the M-House poster in the MH box. The first-year case was pretty straightforward, healthy female, knee surgery, succinylcholine isoflurane. The second-year case he made a little more complicated. It was a laparoscopic appendectomy with a female with Graves' disease, again, succinylcholine isoflurane. More difficult because the laparoscopy, the high CO2 could be from insufflation, and the Graves' disease could be responsible for like a thyrotoxicosis hyperdynamic response. He scored how much they used the MH protocol that was in the MH box, from none, 0 use, to 5, extensive use. He found that the frequency of cognitive aid use correlated significantly with how well they did in following the protocol, statistically significant in both the first and second year group. The first year group, the teams that got the 5 highest scores, used it the most, and the teams that got the 5 lowest scored used it the least. And the same thing was true about the second years. So if you have a list, you're more likely to do the correct steps on a list. That makes sense. But does this make a difference? Again, these lists are based on our best known scientific knowledge at the time. So you would think that following this information would make a difference. And in fact, in advanced cardiac life support, we have some data to support this. So McAvoy in 2014 polled randomly 75 patients who had achieved return of spontaneous circulation, ROSC, after in-hospital cardiac arrest, and 74 patients who did not achieve ROSC. He compared these two groups, and they were similar. If anything, the group that achieved ROSC may have had a little higher illness score. They used 2005 ACLS protocols. What he found was the percent of correct steps positively correlated to achieving ROSC. In fact, there's a dose response. Each 10% increased adherence to protocol, example going from 60% to 70% correct, was associated with a 29% increased chance of achieving ROSC. He also found that each wrong action was associated with a 30% decreased chance of achieving ROSC. So in ACLS, we know that getting the steps right improve your outcome. So how are we going to use our emergency manuals? You'll use it before the crisis, obviously during the crisis, and then after the crisis. Before the crisis, my colleagues commonly, when they have downtime, will be reading the manual just to kind of update themselves. And this is also a really great feature of emergency manuals. If there is a change to the protocol based on scientific evidence, it quickly distributes. So, for instance, when ACLS removed vasopressin from their cardiac arrest protocol, quickly by getting the new emergency manual, you were updated. During crisis, obviously, when the time is right, you pull out the manual and you check to see if you're getting all the correct steps. Now, I tend to use it more after the crisis just because I have to remember to use it during the crisis. Remember, I've been doing this a long time, and I've not been necessarily trained to use it. Sometimes I remember to pull it out when there's an event. Sometimes it's after the event that I'm reviewing what I did. But it's a great learning tool. Did I get all the steps right? Did I miss any steps? What can I learn? How can I improve for the future? Very importantly, just putting the book in the room is not enough. There's more to the process than this. So again, Goldhaber-Faber in that article in 2013 about the nuts and bolts mentioned their experience in the simulation lab where they did a cardiac arrest, and they had the ACLS cardiac arrest protocol printed up and put in front of the defibrillator monitor. So basically all the residents had to move this emergency manual in order to get to the defibrillator. And what you saw in the codes is everybody moved out of the way and they did their thing. But then, when they did the debriefing afterwards, she noticed that there was a lot of errors. And she asked these guys, why didn't you use the emergency manual? And almost universally, the residents said, what emergency manual? We never saw it. And of course, when they reviewed the videotape, they saw themselves all touching the emergency manual, moving it out of the way to get to the defibrillator. So you have to be trained to think about this to use it. Here's some considerations for the emergency manual. Do you want it in paper form? Do you want an electronic form on your computer? Do you want a professional one that you download, or do you want to write your own? So paper has the advantage that it's not technology-based. It's not going to be incompatible with your operating system or your Word program. If there's a failure of technology, you still have the paper manual. Disadvantage is it can be relocated or walk off. There's great information in these manuals, and it wouldn't be unexpected for an anesthesiologist to want to take the manual home to review it at nighttime. There's some cost of printing and acquisition. Like I said, a lot of these manuals are free downloads. So here's how we solve the walking off problem. We chain it to the cart. Mark's our nurse manager. He's an amazing engineer, and here's what he came up with. He zip ties it to the cart with rings and a little light chain, drills a hole through the manual and chains that. And then our manual typically lives on top of our cart. This is the ideal scenario. This is the more common scenario. It's usually buried under something, and that's a unique side effect of the chain, is I can always find the chain to the back of the cart and follow the chain up to wherever the manual might be hidden at the time. Okay, let's talk about electronic manuals and what I call the Where's Waldo effect. I'm not sure what your electronic medical record looks like, but here's a copy of ours. As you can see, it's pretty confusing to find the shortcut on the desktop. Sometimes even starting a case, I have a hard time launching the software just to find it. Can you imagine how hard it would be to find the shortcut for an emergency manual when your patient's got a cardiac arrest? Here's some other thoughts about electronic. You've got to protect it from hacking. You got to worry about availability during computer failure. It's going to require administration IT support to both load it on the desktop and to update it. And finally, simulation testing has made it clear that physical copies are more useful during a crisis. All right, do you want to download one? Do you want to write your own? So my experience is with anesthesia emergency manuals, and we know that we've got the Stanford and the Harvard one readily available. And now this talk is also geared towards emergency medicine, intensive care unit. I'm not sure what manuals you have available, so you may have to write some of your own protocols. But my bias, if you have a professional one, is there's some advantages to that. You've got the prestige and credibility of the author institutions, example Stanford, Harvard. You have standardization of the protocol, and I think you would have reduced medical liability. These are robust departments that put a lot of resources in this to make sure that they are protected. There's also some testing that goes on that would be very difficult to do if you write your own. To make sure these manuals work, they need to be tested in a simulated environment. And that was the example of ACLS handbook may not be that easy to use. In fact, some of the studies I already mentioned, Harrison's MH study, found that the MH poster didn't have high enough priority to the dantrolene, that it wasn't that obvious to give it, and so they actually rewrote the poster. And Neil's local anesthetic systemic toxicity found some ambiguities in the guidelines, and so they also had this one rewritten. And so this is hard to do if you're a private practice and you're writing your own protocols. Okay, here is the Stanford disclaimer. And basically what they say is that this is not a substitute for medical knowledge, training, and clinical judgment. It's just a resource. And I'm going to say that same disclaimer for this talk. Now, I've showed the Stanford disclaimer word for word. So that's okay to do because it's under Creative Commons license as long as I give appropriate citation. So this is from the Stanford Anesthesia Cognitive Aid Group. And then this is the Creative Commons license. Basically it said you're free to print this off. They give you permission as long as you maintain the fidelity of it. You don't change it. They give you a few things you can change. For example, you can add some local emergency numbers. And this is to protect them because they don't want to be liable for some change that you made. So what is the Stanford experience? For over 20 years, they've been teaching simulation-based anesthesia crisis resource management, CRM. Let me divert for a minute and talk about CRM. This originally was cockpit resource management, and that was the pilots in the cockpit. Then they included the flight attendants. It became crew resource management, and then expanded beyond aviation, and that's when we come up with the term crisis resource management. So getting back to Stanford, in 1988, they had their first version of the cognitive aid available for their simulation test-based teaching. In 94, they came out with their first book, Crisis Management in Anesthesiology. You saw the second edition, which was published in 2015. Highly recommend you get this book. In 2003, they had a critical events binder deployed in all the VAs, operating rooms. And in 2012, they actually deployed an emergency manual in all their anesthetizing locations. And this is the culture that my young colleague, Dr. M, was trained in. So let's talk about some limitations. It's just a tool. You need to know how to use it. In common with medical devices, cognitive aids need to have the correct content, be well designed, and be accompanied by appropriate training. You need the right manual, right time, with the right training. Now, I don't have the time today to go into the use of a reader. Amanda Burden has some excellent evidence on how a reader can prompt the use of the emergency manual, and she has a simulation based on a maternal cardiac arrest. When I presented this to the anesthesia education meeting, I went over the reader's role. And before the meeting, I'd handed out a copy of the Stanford Anesthesia Manual. And at this point, I asked everybody, what does the Stanford Anesthesia Manual say about timing for the emergent C-section in maternal cardiac arrest? And the pages started flipping. And it was actually a trick question because that is not in the Stanford Manual. And that's one limitation of emergency manuals. Not everything can be in the manual. So you've got to be familiar with your manual. And it's just a tool. You've got to know when to use it, but it's not going to substitute your clinical judgment, and there's no cookbook approach to emergencies. You got to be careful that you don't be distracted by the manual. It could actually increase the risk and add to a more adverse outcome. Most important, remember, is it's not first line. A patient in cardiac arrest needs CPR, not go get the book. And this is where the importance of pre-crisis training is. So you know the first few steps to get initiated. And then when you've started the process, you can get to the manual to see what other important steps you need to do. So here's how I look at it. Choosing to use an emergency manual is like using your book during a test. You get the same test. Who wouldn't want the option of being able to use their book? Of course, you're not going to go buy the textbook the day before the test and then crack the plastic just as you're walking into the exam. Preparation time will improve performance. So in conclusion, consider emergency manuals another medical device that can improve care. The Sim Lab has demonstrated improved accuracy and fidelity when using emergency manuals. And in ACLS, we have found that accuracy may equal lives saved. You need to develop expertise and experience to best use this new device. We found the Stanford Manual is a great start, but by itself, it's not enough. I'd like to close with a call for action. This anonymous quote, and this is a tale about 4 characters: everybody, anybody, nobody, and somebody. There is an important job to be done, and everybody was asked to do it. Anybody could have done it, but nobody did it. Somebody got angry about that because it was everybody's job. Everybody thought anybody could do it, but nobody realized that everybody wouldn't do it. It ended up that everybody blamed somebody when actually nobody did what anybody could have done. Be somebody, make this happen in your operating room. I thank you for your time and attention and interest. Please send me back any feedback at john@saferanesthesia.com. Thank you.